All right, let's do something a little different today. We're going to step into the pressure cooker of a surgical consultant exam, a viva to be exact. The topic? Damage control surgery. I'll be playing both parts, the tough examiner and the candidate on the hot seat. Let's see how this goes.
So here's our game plan. We're going to follow this case right from the moment the patient hits the trauma bay. We'll cover that critical decision to switch gears to damage control, what actually happens in the OR, how we deal with specific organ injuries, and of course, the crucial post-op period. We'll finish up with some key takeaways and pitfalls to avoid.
Okay, deep breath. The exam starts now. The clock is ticking, and this first question really sets the stage for everything that follows.
Examiner, candidate. You have a 23-year-old male, victim of a high-speed car crash. He's just arrived. BP is 90/60, heart rate's 130. Tell me exactly what you're going to do.
Thank you, sir. My immediate response would be to lead the trauma team using the Advanced Trauma Life Support, or ATLS protocol. We'd run through the primary survey. That's airway with C-spine protection, breathing, circulation with a focus on stopping any bleeding, disability, and exposure. Given his vital signs, I'm assuming he's in hemorrhagic shock, so top priority is getting 2 large-bore IV lines in and starting resuscitation with blood products now.
Okay, the patient is stabilized enough to get to the operating room for an emergency laparotomy. But this is major trauma, and things are about to get a whole lot worse.
Right. Candidate, you've opened the abdomen, and it's full of blood. Your anesthesiologist is telling you the patient's pH is dropping, his temperature is plummeting, and his blood isn't clotting, even with a massive transfusion. What's your strategy now? Sir, this patient is circling the drain. He's developing what we call the lethal triad of trauma. What's happening here is a vicious, self-perpetuating cycle. The acidosis and the cold are stopping the clotting factors from working, which means more bleeding. And that bleeding makes the acidosis and the heat loss even worse. It's a physiological death spiral, and my entire surgical plan has to change immediately.
These vital signs are a textbook indication to stop what I'm doing and pivot to a damage control surgery approach. The goal is no longer a perfect, definitive repair. Not at all. The goal is to get in, stop the massive bleeding, control any spillage from the gut, and get this patient out of the OR and to the ICU so they can fix his physiology.
Correct. You've made the call. Now, walk me through the initial steps of your damage control laparotomy. I want precision.
Certainly. First, a long midline incision from the breastbone to the pubic bone for maximum exposure. I'd give the anesthesia team a heads up just before I open the peritoneum because the blood pressure will likely drop. Once inside, I'll scoop out all the blood and clots, then systematically pack all 4 quadrants of the abdomen. This is basically hitting the pause button. It buys the anesthetist precious time to catch up on resuscitation. Then, I'll remove the packs one by one, starting where I least expect an injury, to try and pinpoint the source of the bleeding.
Very good. You remove the packs from the right upper quadrant, and you're staring at a significant liver injury. What are your damage control options here? For the liver, it's a graded approach. If I see a single bleeding vessel, I'll try to clip it or tie it off. For a deeper bleed, I can perform a Pringle maneuver, clamping the main blood supply to the liver, which might give me a window to throw a few quick stitches. But if all else fails, the definitive damage control move is to pack it tightly and correctly. And the one thing you don't do is open a contained hematoma behind the liver that isn't actively bleeding. That's a classic way to turn a survivable problem into a fatal one. Good. The liver is controlled. Now you move to the pelvis and find that the external iliac artery has been completely transected. What's the damage control maneuver here? In a patient this unstable, my only priority is to get blood flow back to that leg immediately. We're not doing a complex, beautiful repair. The move here is to place a temporary intravascular shunt. It's essentially just a simple plastic tube that bypasses the injury. It saves the limb, and we can come back and fix it properly later. But before that shunt goes in, there are 3 absolutely critical maneuvers. First, I have to check for back bleeding from the downstream artery to make sure there's no clot blocking it. Second, I'll flush both ends of the vessel with heparinized saline to prevent new clots from forming. And third, if there's been a long delay, I have to do a fasciotomy on the lower leg to prevent compartment syndrome once blood flow is restored.
Excellent. Now, let's go to the left upper quadrant. You find a shattered spleen, a grade 4 injury, and it is bleeding profusely. What is the management?
In an unstable patient with a major splenic injury, there's absolutely no role for trying to save the spleen. It's a liability. The definitive damage control procedure is an emergency splenectomy. Get it out, stop the bleeding, and move on. I'd start by mobilizing the spleen, dividing its attachments to get it up into the operative field. The most critical step is carefully ligating the splenic artery and vein right at the hilum, making absolutely sure I don't injure the tail of the pancreas, which sits right there. After it's out, I'd meticulously inspect the area to make sure all the bleeding is stopped.
Okay, quick fire. Your damage control principles for the kidney and the pancreas.
For the kidney, if I see a contained hematoma that's not expanding, I leave it alone. If it's bleeding uncontrollably and I know the other kidney is normal, the answer is a quick nephrectomy. For the pancreas, it's simple. First, control any bleeding. Second, control any contamination from a duct injury with wide drainage. That's it.
And if you find an intestinal injury, the goal is just contamination control. If it's a small, clean tear, a quick suture repair is fine. But for a really destructive injury, or if the patient is just too sick, the fastest and safest thing to do is use a stapler to divide the bowel and just leave the two ends. We'll put them back together another day.
Very good. You've controlled the bleeding, managed the contamination, you've packed the abdomen, and you've placed a temporary closure. The patient's on his way to the ICU. The first battle is over. But now we move to the next critical phase.
So, in the ICU, what are you most worried about? And what specific signs would trigger an immediate, unplanned trip right back to the operating room?
My number one concern post-op is abdominal compartment syndrome, and I'd have an extremely low threshold to go back to the OR. The hard signs, the real red flags, are worsening lactic acidosis, persistent low blood pressure that isn't responding to resuscitation, or a coagulopathy that's getting worse. Any of those tells me we have ongoing bleeding or contamination that we missed.
The patient stabilizes. 24 hours later, you take him back for his definitive operation. What are the key principles of this second-look surgery?
The most important principle, bar none, is to assume you missed an injury the first time. This isn't a quick peek, it's a complete, meticulous, top-to-bottom re-exploration. We take the packs out gently, sometimes underwater, to avoid pulling off clots. A final X-ray is mandatory to make sure no sponges are left behind. Only then do we start the definitive repairs, like converting that shunt to a proper graft or sewing the bowel back together.
We're now at the last section of the exam. This is where a candidate can really show they have a deep, practical understanding of the topic by hitting on the most critical, high-yield points. So, what is the single most important mindset to have when going in for that second-look operation?
You have to assume you missed something. The first operation was about surviving a hurricane. The second operation is about carefully inspecting the damage. Complacency is your worst enemy.
What are your options for that temporary abdominal closure? The two most common are the Bogota bag, which is basically a sterile plastic sheet sewn to the edges of the wound, and the commercial negative pressure dressing systems. The Bogota bag is simple and lets you see the bowel, while the negative pressure dressings are fantastic at managing fluid and helping to reduce all that swelling. Both are designed to prevent abdominal compartment syndrome. And what are the key complications of a splenectomy? Immediately, we worry about injuring the things next door, like the tail of the pancreas, which can cause a nasty leak, or the stomach. Bleeding and abscess are also risks. But the most significant long-term danger, the one we have to counsel patients about for life, is overwhelming post-splenectomy infection, or OPSI. It's a rare but deadly risk.
Very well, candidate. We'll end with one final question to tie it all together. Your patient has survived against all odds. You are about to perform the definitive operation. What is the single philosophical principle you must carry into that room?
Sir, the principle is one of humility and diligence. The first operation was about saving a life. This second operation is about restoring a patient. You have to be systematic and assume something was missed, because the one thing you don't look for is the one thing that will be there.
Excellent. That concludes the examination.